The connection between low vitamin B3 levels and chronic fatigue syndrome, CFS, also known as myalgic encephalomyelitis, ME/CFS, is gaining increasing scientific attention, yet it remains underrepresented in mainstream medical treatment. CFS is a complex, debilitating condition characterized by profound fatigue, post-exertional malaise, cognitive impairment, and a constellation of multi-system symptoms. Despite its significant impact on quality of life, treatment approaches often remain symptom-focused, neglecting potential metabolic routes such as niacin deficiency and NAD+ depletion. Niacin's relevance lies primarily in its essential role as a precursor to NAD+, nicotinamide adenine dinucleotide, a molecule central to mitochondrial function, redox balance, and cellular energy production. In healthy individuals, NAD+ allows mitochondria to convert nutrients into ADP, the body's basic unit of energy. In CFS patients, multiple studies have identified abnormalities in mitochondrial respiration and energy metabolism, including low levels of NAD+ and related cofactors. These deficiencies can impair cellular ability to produce energy efficiently, leading to the profound exhaustion and physical collapse typical of CFS. Recent metabolomic studies have reinforced this idea by demonstrating biochemical signatures of mitochondrial dysfunction in CFS patients. These profiles include suppressed levels of amino acids, altered fatty acid oxidation, and most crucially, low NAD+ availability. The result is an energy deficit that not only affects physical stamina but also brain function, immune regulation, and recovery capacity. Niacin, through its role in restoring NAD+ pools, is uniquely positioned to intervene in this core metabolic dysfunction. However, treatment paradigms for CFS often focus more on symptomatic relief than on correcting these deeper biochemical imbalances. Patients are commonly prescribed antidepressants, pain medications, or behavioral therapies such as graded exercise and cognitive behavioral therapy, none of which directly address mitochondrial or NAD+ dysfunction. This disconnect between symptoms and cellular causality may explain the poor efficacy of many standard approaches. Meanwhile, potential metabolic therapies, including niacin or NAD+ precursors like nicotinamide riboside, NR, and nicotinamide mononucleotide, NMN, remain relatively unexplored or reserved for experimental use. What's particularly striking is that niacin itself is inexpensive, safe, and readily available. Unlike NR or NMN, which are more costly and often patented, niacin and niacinamide, non-flushing, offer practical avenues for NAD+ replenishment in clinical or even self-care contexts. Anecdotal reports from patient communities have described improved energy, cognitive clarity, and post-exertional recovery when using niacinamide at moderate doses. These individual cases, while not a substitute for clinical trials, underscore the urgency of exploring niacin more systematically in this context. Furthermore, chronic inflammation, a frequent companion in CFS, is known to accelerate NAD+ depletion. Inflammatory cytokines increase the activity of NAD-consuming enzymes like PARPs and CD38, which degrade NAD+ during DNA repair and immune response. This creates a vicious cycle. Inflammation depletes NAD+, mitochondrial function worsens, and the body has even less capacity to combat inflammation or produce energy. Niacin, by supporting NAD+ regeneration, could help interrupt this cycle. Despite these promising mechanisms, research funding and clinical attention are typically directed elsewhere. One reason is the complex and poorly understood nature of CFS itself. The condition has long suffered from scientific neglect and social stigma, in part due to its elusive biomarkers and overlapping symptoms with mood disorders. This has led to fragmented research efforts and a lack of consensus on core pathology. As a result, relatively straightforward interventions like vitamin B3 remain on the sidelines, while more exotic or expensive therapies are given priority. Moreover, the narrative surrounding fatigue often conflates mental burnout, lifestyle factors, or psychological distress with deeper physiological dysfunction. This has made it harder to recognize the legitimate biochemical deficits, like low NAD+, that may drive CFS. It also reflects a broader issue in medicine: the underestimation of micronutrient status in complex chronic conditions. While obvious nutrient deficiencies like scurvy or rickets are easy to diagnose and treat, subtler, functional deficiencies, where levels may be technically normal but biologically inadequate, often go unnoticed. In conclusion, low niacin status and subsequent NAD+ depletion may be central, not peripheral, to the biology of chronic fatigue syndrome. Mitochondrial dysfunction is not merely a symptom, but potentially a root cause of the illness. Addressing this with targeted niacin supplementation, especially in its niacinamide form, could offer a safe and scalable approach to improve energy metabolism, reduce oxidative stress, and support immune balance. As science continues to uncover the metabolic signatures of fatigue, niacin may emerge not just as a supporting actor, but as a key protagonist in restoring vitality in CFS.